Hello, my name is Taye Louie, and this summer I was fortunate to participate in a 3-month global health internship in Uganda with the Simulation for Life team, or SIM team, at the Mbarara University of Science and Technology. I'm privileged to be able to present some of the research that I helped contribute towards, which specifically was a study that took place in southwestern Uganda at the beginning of the COVID-19 pandemic. And this study investigated the effectiveness of a clinical decision support application on neonatal outcomes. To give some background, 98% of the 2.3 million annual neonatal deaths occur in low to middle income countries like Uganda, largely due to limitations in access to specialized clinical care. In Uganda, the majority of births and thus newborn care occurs in rural health facilities, where the care is mainly provided by nurses and midwives who do not have specialized training. Though referral to facilities with greater specialization, such as in neonatology, is common, inefficiencies in recognition of clinical emergencies by healthcare providers combined with long transportation times often results in large delays that can be fatal to the already fragile newborns. Clinically, the neonatal mortality rate in Uganda is over 5.5 times greater than that in Canada, which is unacceptably high. To try to reduce this disparity, with the increasing prevalence and accessibility of smartphones in low to middle income countries, there's been a growing interest in exploring whether these tools can be leveraged in healthcare settings to improve clinical care. The SIM team specifically designed their own clinical decision support tool known as PRISMS, or Protecting Infants Remotely via SMS, which is a mobile application informally known as a pocket pediatrician. Now, PRISMS got this name due to its ability to take in basic and readily available newborn information that can be easily obtained by even unspecialized healthcare providers, such as baby weight, temperature, and color. And using this information, PRISMS can generate a specialized care management plan for the newborn with detailed information that explains each piece of guidance. Now, the SIM team has previously validated PRISMS as an effective tool in generating guidance comparable to that of experienced physicians. However, the clinical impact of PRISMS on actually improving newborn care and newborn outcomes has yet to be confirmed. So, the purpose of this study was to do precisely that, to investigate whether implementation of PRISMS following refresher training for healthcare providers can improve newborn care and reduce newborn mortality in health facilities across southwestern Uganda. To go over the study design, 36 health facilities were split between the control and intervention arm with matched facility characteristics, and in both arms, healthcare providers were given baseline refresher training in newborn care. To ensure that there was no knowledge and skills decay, or at least to minimize the degree of this, peer-to-peer learning, which is an active rehearsal strategy, was employed throughout the study duration, and the effectiveness of peer-to-peer learning was confirmed with mentorship sessions, which basically ensured that the peer-to-peer learning standards were upheld throughout the entire study. Now we'll focus specifically on the first 12 months of this diagram here, where the intervention arm was given exclusive access to PRISMS. And looking at the results, over this 12-month period, over 10,000 newborn cases were studied. And when comparing the intervention arm to the control arm, there was an observed 18% lower mortality in the intervention arm, which had access to PRISMS. Furthermore, there was an 80% greater referral rate in the intervention arm. And finally, it's important to note that the overall utilization of PRISMS was relatively low at 30% across all facilities. So, in terms of the significance of these findings, they demonstrate that PRISMS was associated with a significant decrease in neonatal mortality, which is a testament and provides strong evidence to its clinical use. Future research should focus on scaling up the deployment of PRISMS while specifically focusing on longitudinal changes in newborn outcomes before and after implementation of PRISMS in specific healthcare facilities to confirm that any effects are directly based on the use of PRISMS. Now, with that, I'd like to conclude my presentation. But before I do so, I'd just like to give a special thanks to these key individuals who are involved with my project. Thank you.